Welcome once again to the Race Academy webinar series. We have another 30 seconds away. We've got our last of the people signing in for today's webinar. Just to touch base with the people from New Zealand. G'day everyone in New Zealand. We've got our Australian contingent. Malaysia, hello to our Malaysian crowd. Fiji, wonderful to see some Fijians with us today. Hi everyone over there. Wish I was there with you today. United States and Singapore. So we've got quite a multinational group today, so I'm very proud to have you all aboard. Today we have again Dr. Geoff Hall, who is the pioneer of modern day dental education when it comes to orthodontics. He's a good friend. We've been working together for a long time, so I always love to have Geoff on board. So today's topic, the orthodontic restorative interface, improving the outcomes for your patients. It's a two-part series. Number one will be today when I introduce Geoff in another few seconds, and next week will be part two. So definitely something to sign in to tune into for next week to see Geoff's part two of the improving the outcomes for your patients. But yeah, again, I just wanted to touch base that Geoff was the first person outside of the United States to do an Invisalign case. So he's definitely the right person to be leading us today. He's the founder of the OrthoEd Institute. So there's no one better to take us through the restorative and orthodontic interface. So with no further ado, I'd like to welcome Dr. Geoff Hall.
Matt, once again, thank you for your very, very kind introduction. And thank you to Race and everybody else there for inviting me again, because I take that as a real privilege and honour to be able to present to your group. And I think this particular presentation, especially for all of you guys who are doing restorative dentistry, which is probably 99% of you out there, this particular presentation I think will bring a lot of points and hopefully a lot of pearls to how you can improve the outcomes for your patients. So this lecture is titled, as Matt said, the Orthodontic Restorative Interface. Most of you have heard me, you now know who I am, so I'm not going to bore you with all that, but I do have a really strong bias in teaching general dentists. Now, whether it be setting up study clubs, but education to me is the goal. Okay? That's what my legacy is in my latter part of my career, and that's what I want to bring to you guys. I've done it over 10,000 patients myself, been involved as an specialist orthodontist for now over 30 years, and some people call me the Orthodontic MythBuster, and hopefully I'm going to present and break down some of those myths in this presentation today. So, in this particular part one, I'm going to discuss the four topics: the management of the gingival architecture, orthodontic extrusion and altering the bony architecture, how do we manage ankylosed incisors, and I'm going to talk about the orthodontic and periodontic interface. That's in part one. In part two, which is next week, we're going to discuss guidelines in setting up restorative cases, ideally from an orthodontic perspective. How do we manage missing teeth? How do we manage orthodontically that worn dentition that we see in a lot of adults? And then we're going to discuss this topic, which so many myths about microimplants, or what some people call TADs, temporary anchorage devices, and talk about when are they actually clinically useful and when are they just a gimmick that the supply company is going to sell you these microimplants and you're going to have a problem. So we'll discuss that in next week's lecture. So what I want to discuss today is periodontal issues. How can orthodontics improve this type of situation? So we went from here before to here afterwards, non-extraction, by moving the root into the bone. This would have been considered a total extraction case. But with orthodontics as well, we can improve the prognosis of that tooth significantly. We can talk about missing teeth. When do we open spaces? When do we close spaces? What's the best position for teeth to come through in when teeth are missing, etc. So we're going to give you some guidelines. We're going to talk about bone regeneration. How do we improve the bone on this upper left central incisor without having to do bone grafting and gum grafting? How can we use orthodontics to our advantage by regenerating bone? So The first part is very basic, but it's essential to the understanding of what orthodontics can do. So we've got to understand the management of the gingival architecture. And this is really designed more for adults to start off with. So we're going to talk about interdisciplinary therapy. And very important to understand, when we talk about this term, we use a lot of lip service. And if you're going to use this term properly, it's a combination of regimental diagnostic, treatment planning, and therapeutic procedures with extensive communication between the team members. And if you notice, the word extensive is in bold. It's not just writing an email to the prosthodontist or to the endodontist or the orthodontist. It's sitting together as a team and discussing the case. And included in this team should be the technician, because they are a really important part of what can they do to help you in these type of cases. So they should actually be a member of this interdisciplinary team. So everybody knows this, but let's put it into some scientific perspective. What is the ideal gingival form? And basically, we want to see the gingival margin of the central incisors and the canines at the same level, and the central incisor, the lateral incisor, to be about 0.5 millimetre different, 0.5 millimetre to 1 millimetre more coronal than the central and the canine gingival margin. That seems obvious, but we don't. And it seems obvious when we look at it in a slide and a textbook, but we don't look at this enough clinically. That's the ideal gingival form. We want to see the contour of that gingiva should mimic the CEJ. And we also want to see the papillae actually occupy half that interproximal contact. And we're going to show you some cases later on, which I hope will blow your mind to what we can do. And we also know that, and obviously Matt and all the people at Race know this better than even anybody else does, there is an ideal, from an aesthetic point of view, height to width ratio of teeth. So a pleasing ratio would be somewhere between the 75 to 80%. We can sometimes have teeth which are too long in relationship to their width or too wide in relationship to their height, both of which are displeasing. So the ideal height to tooth ratio is somewhere between 75 to 80%. We know that. This is the basic architecture that we're looking for. Now let's look at this more clinically and go, okay, we've got an adult patient and we assess that patient and there's a discrepancy between the gingival margins. So let's have a look. So here we are. No longer do we have the gingival margin, the central, at the same level as the canine, nor do we have the lateral about 0.5 millimetre to 1 millimetre more coronal to the canine. So we may have had over eruption of these teeth, we may have, okay, or we may have other issues that could be causing this, we'll say, for want of a better phrase, this lack of harmony of the gingival margins. This is where the diagnosis comes in, and it's very, very important, the diagnosis here. So this lady comes in, and we've got a situation where the gingival margins are no longer level, and we've got to determine what's caused this. What has caused this lack of harmony with the gingival margins? So there are two main reasons. One reason is what we call differential extrusion of teeth. So what happens is when teeth wear down, there is compensatory eruption of those teeth. And when those teeth erupt, they bring down the gingival margin and the whole periodontal apparatus with it. And that's what we call differential extrusion of teeth. So how do you diagnose that this case has got differential extrusion of teeth? Well, firstly, by definition, you need worn teeth. So you need compensatory eruption to occur because of the wear. So you hardly ever see this in a child. This is more an adult. So do you see a difference in the height of gingival margins in an adult? You look for worn teeth. And to check that they're worn, you check from the occlusal view and see that there's an increase in thickness of the incisal edge. and then you have a normal probing depth to the CEJ. Now, what's important here is there's a normal probing depth to the CEJ. So a lot of people would look at that and go, let's go ahead and crown lengthen. But if you go ahead and crown lengthen, you're now crown lengthening onto the root of the tooth, which is not as good to put a restoration on. So the treatment of choice when you've got differential extrusion of the teeth because of worn teeth, the treatment of choice is to intrude those teeth orthodontically and level the gingival margin. And I work with a prosthodontist in Melbourne a lot called Andrew Dillon. And Andrew says to me, Jeff, you do the pink and I'll do the white. So he said, you get the gingival margins right and I will go ahead and put the crown on, okay? And this is the key. And I explain to my patients, this is a little bit like building a house. What I want to do is set up the foundations correctly and then you can put the second story on. So patients who have worn teeth. So for example, here we've got, you can look at the incisor ledge and you can see how the increase in the thickness of the incisor ledge because that tooth has been worn. Look at the gingival margin, the differential between the two centrals. They should be at the same level. So what we do is orthodontically intrude that tooth, level the gingival margin, and then you guys could go ahead and put the put a veneer, crown, whatever it be, the old expression, fix up the pink, and then anybody can do the white. Okay. Now you could do that with aligner therapy as well. You don't need fixed braces. So whatever way you want to do it, but the point is we want to level the gingival margins by intruding the tooth that is over erupted. We look at the cause of the problem. So we intrude and restore. So this is this lady here. Look at how they're extruded. So we've gone ahead and we've actually gone ahead now and we're going to intrude these anterior teeth. So we've now gone ahead and intruded the anterior teeth to level the gingival margin, and then we're going to go ahead and do the restorative work. So we made that decision that the CEJ, that we probed and we right at the CEJ, the teeth were worn. This was a case of differential extrusion of the teeth. So we've gone ahead and now we've gone ahead and done the crowns on those teeth and have a look at the difference in the facial, in the aesthetics of this patient. Because what we've done, if you went ahead and crown lengthened here, we would have made those teeth so long. We would have made those teeth so long, and we would have been onto the dentine or onto the root surface, the cementum, which would not be a very long-term satisfactory restoration. So that's one cause. The other cause is what we call altered passive eruption, where you've still got the excessive gingival tissue present, but there's basically an altered pocket. So you've got a perioprobe to find the CEJ. So for example, here, and you see this more on younger children, where you do your bone sound and the CEJ is right up here. So you've got altered passive eruption. These are the cases where you go ahead and crown lengthen. There will not be any wear of the tooth. There won't be any wear of the tooth. And when you perioprobe, there will be a soft tissue pocket there. So these are the cases where you go ahead and crown lengthen to remove the excessive gingival display. So you're going to perioprobe and you're going to see, and this is what you see on younger children, because it's very unlikely, very rare that they're going to get wear of those teeth. And hence, it's unlikely to be a case of differential extrusion problem in those young children. So it could be either altered passive eruption or the differential extrusion. Crown lengthening is perfect when you have altered passive eruption. But remember, you also have to make sure that you don't encroach on the biological width when you do that. And I tend to refer my patients to a periodontist, so we make sure that there's enough gingival sulcus, and sometimes we need some bone removal as well. But I leave that decision to the periodontist. So this was the other patient we showed you, where we've just done crown lengthening. So you've got to look at what the cause of the problem is, the diagnosis, and then make the best decision for that particular patient. If that patient had lots of wear and was an adult, we may have intruded that first and then done the restorative work, okay? But you've also got to remember there can be other causes of excessive gingival display. So altered passive eruption is one very common cause. Differential extrusion of the teeth is another common cause with our adult patients. But you could also have vertical maxillary excess, and sometimes you could have excessive mobility of the lip. So if you've got vertical maxillary excess, that's because the whole maxilla has overgrown vertically. And the last thing you want to do here is go ahead and crown lengthen, because you'll be down to halfway down the root. So you've got to diagnose this correctly. And these cases sometimes require orthodontic surgery to obtain the best aesthetic result. So sometimes we do surgery where we basically take a wedge of bone out from the maxilla, and then we move the maxilla up. The mandible rotates forward, so it also decreases that facial height, because most of these patients who suffer from VME or vertical maxillary excess have a long lower facial height as well, okay? So that's one cause that we have to look at. And you can make stunning changes if you get the right diagnosis. These patients who worry about their gummy smile, etc., you make the right diagnosis, it's life-changing for them, okay? And then the other area which is becoming more and more common is using Botox therapy, even if it's just as a diagnostic guide. For example, this patient here has got what we call a hypermobile lip. The upper lip just moves up too far. So we can put Botox in and see what happens, reduce the amount of gum display. It's also a really good tool if patients don't know whether they really want to do surgery or not because of their vertical maxillary excess. To use Botox as an interim measure can be really good as a diagnostic aid, because the patient goes, well, you know what, it hasn't changed my life. Or the patient may say, well, I am so much more confident. And if that's the case, then you look at a more permanent resolution, which could be your surgery. But it's a great diagnostic aid as well. So keep that in the back of your mind. This is a great case. So this girl comes in, she's about 13 years of age, and she avulsed her upper left central incisor. And I had no idea what to do. You know, people could, there are all different options. And some of you are going to say, well, we could have taken out the upper right four, and we're going to move everything around and open the space, etc., etc. But, you know, it's very hard to get really good aesthetic implants, I think, especially in the upper central incisor region, especially with a growing patient as well. So we call this, where I trained in Philadelphia, we call it a therapeutic diagnosis, which means I've got no idea what I'm going to do, but I'm going to put the braces on, I'm going to line up the teeth, and then I'm going to reassess. So that's what I did. I put the braces on, I lined up the teeth, and after about 5 months, I go, wow, that looks so much better. Except, look at the problem we've got with this is the lateral incisor. And I thought to myself, if I go with my principles that I'm talking about, if I intrude that lateral, get the gingival margin level, I could make this, and then we build that up into our central incisor. I could also, if I really want to take it to the next level, I could extrude the canine significantly, bring down the gingival margin, and make that look into a lateral. And if I wanted to even take it to the nth degree, I could intrude the premolar, so my gingival margin would now look like a canine, and then I could put a crown or a veneer or something else on that tooth. Okay, so with our knowledge of basic gingival architecture, I went ahead and I put the brackets on, and I intruded that lateral incisor, and then I realised though, if I was going to increase the length of that, I also need to increase the width, because I have to get the right height to width ratio that we talked about. So I put the little open coil spring in, I'll get the correct height to width ratio, and this is how I finished it. So I used the lateral as my central. Now, I'll be honest, it's not the greatest restorative work because I didn't do it. And trust me, even if I had done it, it wouldn't have been that great anyway, because I can't do restorative work and my life depended on it. But this is just a good temporary. And and now I should have extruded that canine a bit further to bring the gingival margin down. But the point I'm trying to get at is we can do some really good stuff with these difficult patients by just understanding what we need to do from a gingival architecture point of view. So if you keep in mind that these difficult patients, get the pink right, and then you can do the white. That's the biggest problem we have in aesthetics, is not getting the gingival margin right. And this was a case by a friend of mine, Bjorn Sacrison, where there was a valsed upper central. And what he was trying to prove, and he proved it very successfully, I think, is that the aesthetic result is far better by using a natural tooth with a crown or a veneer than putting an implant in there. So he moved the lateral into the central side. He then went ahead and intruded the lateral, just like we did on that last case, to level the gingival margin. And now he can build that tooth up. So he ends up with a beautiful result. And I think that's a better result than what you would get cosmetically with an implant, especially in a growing patient. So this just gives you a way of doing things a little bit different. Okay. So one of our big problems that we have is management of the black triangle. Okay. And you're going to look at that and go, Jeff, that's ridiculous. How can I manage that? Okay. So what we know is that this papillae is a fixed amount. And the problem why we have a black triangle is that the contact point is in the wrong position somehow. And what we know from our research now is if the contact point is within 5 millimeters of the bone, there will be no black triangle. Okay? Because what basically happens is it's a fixed amount of papillae, and what we're doing is we're squeezing that papillae into this area in the contact point. So we can get our contact point within 5 millimeters of the bone, we squeeze our papillae into that amount, into that space. So 3 reasons why we have black triangles, or what we call missing papillae: diverging roots, abnormal tooth shape, and very, very, very rarely is it patients with advanced perio. That's what we'd like to tell people, but it's very rare. So for example, this guy comes in and look at how the roots are diverged. And what we want to get the contact point within 5 millimeters of the bone. Now this was a case I did back, I think it was 2000, before I even understood what I'm talking about today. And we went ahead and we closed up the space. Look at how that improved. But if I did that today, it would be far better, because what I've got right here, the contact point is still not within 5 millimeters of the bone. And I can sit there and say to you safely, if I cut back these line angles or flatten these line angles, I would have no black triangle. And I'm going to prove that to you in a minute. So, and in fact, these adult patients, if you look at this, I would argue that the bone is far better after I've done orthodontic treatment than beforehand, because I've now got the teeth in the right axial inclination. So we can improve a lot of these perio issues by improving the axial inclination of teeth as well. So orthodontic extrusion and altering the bony architecture. So to take you one step further in this discussion. So in the old days, we used to do these forced extrusion when there was subgingival fractures, and you would have to extrude the tooth, the bone comes down with it, you would have to do some perio surgery to restore that biological width. But there was a problem as you extrude teeth, you're bringing down the narrower part of the root, and that became a problem with the emergence profile. But that's what we used to do routinely on lateral incisors. But the other advantage is by extruding the teeth and we cut down the crown, we improve the height, we improve the crown to root ratio. So it becomes a much better mechanical situation. Whereas here, if you put pressure on a tooth, it's more likely you're going to lose more bone. If you've got a 1-to-1 crown to root ratio, the tooth is far more stable long term. So when we go ahead and extrude a tooth like this central, or could be lateral, we extrude the tooth and we're bringing the narrower part of the root down further. We take away some of the bone to achieve our biological width requirement. Okay, so we can do that, but now we have a problem with the emergence profile. But what we learned from this is that as we extrude the teeth, we bring the bone down. And here we're extruding this upper central incisor. We're bringing the bone and gum down. And once again, to quote my famous periodontist, Andrew Dillon, he said, you do the pink and I do the white. And we all know that when you put an implant in, you're going to lose a little bit of gum. So the more we can bring down the tooth, the more bone we can have, the better. We could get a much better cosmetic result. So we found that as we extrude teeth, we can actually improve the gum and the bone. And we get some beautiful cosmetic results by doing so. So have a look at this person now. So to take it to the next level, you're going to say, well, look at this. How do I get rid of this black triangle, et cetera, et cetera? So basically what happens is we go ahead and we put some brackets on. And look how far I've extruded that tooth, because this bracket now is about at this position here. So I'm extruding that tooth, bringing down the bone and the gum, and I'm actually extruding it to the point of extraction here. So I'm extruding this tooth to the point of extraction. And then we're going to put an implant in. So I'm extruding the tooth, so I'm bringing down the gum and the bone, then we can put the implant in, and when we finish, the implant's in here. I've extruded it to the point of extraction, and look at the end result that we've got by what we've done orthodontically. No bone grafting required, nothing like that. So we're using the teeth and the bone to our advantage. And we're going to talk about more of that in part 2 as well. Okay. So look at the difference with her. Okay. So another patient where we've basically got a fractured root, I think it was. The prosthodontist said, Jeff, could you please extrude this tooth for me? And I'm going to put an implant in. So once again, we just put the brackets on, very, very simple. I have to be honest, this is far more effective to extrude teeth with braces than it is with aligners. Aligners can be very difficult to capture for the extrusion process, but very simple that any general dentist can do. We bring the tooth down, and you can see the difference in the gingival margin, and you can see how much I've had to cut back of the tooth, because as I extrude it, it's going to have an interference on the lower anterior segment. So at that point, I've cut it down. The prosthodontist has decided to take it out and just build up a temporary bridge in the interim. Then he's going to put the final implant in, et cetera, et cetera. This happened to be the daughter of an older dentist, by the way. So, but the point here is, by doing what we've done, we're going to improve the situation significantly from the bone point of view. Otherwise, you'd have the implant in if the dentist did it, if the prosthodontist did it at the beginning. If you put the implant in, you lose another 2 to 3 millimeters of gingival display. And if you've got a high lip line, it would be an aesthetic disaster. So, doctor, I've got a toothache. I do love that one. So, ankylosed incisors. So, unfortunately, we see this occasionally, and it's a real problem. Okay, it can be a real problem. So, how do you manage this ankylosed incisor? Because as the patient keeps growing vertically, these posterior teeth are going to keep on erupting, and this tooth just stays. It's like an implant. This is the reason why we do not put implants in growing patients, especially anteriorly, because everything else will grow vertically except for the tooth that's ankylosed or the implant. So, where it could be due to trauma. Now, where I was in Philadelphia, they called ankylosis replacement resorption. So the endodontic department there said, see how they're actually, you can see this on the CBCT, that the root is being replaced by bone. In other words, the tooth can't tell the difference whether it's bone or tooth, and it keeps on resorbing together. And so by definition, an ankylosed tooth will resorb totally over time. So how do you fix it from a restorative point of view? Very, very difficult. So, because if you go ahead and put brackets on here, what's going to happen? Everything else is going to intrude to the level of that ankylosed tooth. As I said, it acts like an implant. So there are different ways you can put a TAD micro implant, and we'll talk about that in part 2, on the lower arch. And so you're just going to run an elastic from there to that TAD to pull it down so it doesn't have any unwanted reciprocal side effects. Or the other option, which is probably more predictable, is you basically put in a little plate and you do a little segmental osteotomy, where you're just going to cut the bone in that one segment and the screw is going to pull down this whole segment. So that's another option, because how else are you going to restore that patient? Just about impossible. So this girl comes in, lovely girl. And I was pretty stupid about this particular patient. But so it was ankylosed, and I didn't really understand at the time. So it had been endodontically treated, obviously ankylosed. So I go ahead stupidly and put a bracket on that tooth. And what happens is I put the bracket on that tooth, everything else is moving the wrong way. So I had to say, stop using the 1-1. And I just basically lined everything else up. And this is what she was like after my treatment. I couldn't move that tooth down. So this is what she was like after my treatment. And the dentist said, look, she's a lovely girl. Can we do something here? So he decided to put an implant in a bit early, okay, which I was a little bit against, but it was done anyway. So the implant's in the 1-1. And then he said, but Jeff, what I want you to do is I want you to bring down that upper right lateral. Let's level the gingival margins. Exactly what I've been talking about previously. Give her a much better aesthetic outcome. So we use this implant now as our anchor for our other tooth movement. So I put the brackets on. I'm going to extrude the 1-2, okay? So and I'm going to even extrude the 2-1 a little bit to level the gingival margins. And I've got some other appliances on to more just to counteract the reciprocal side effects. So here we are, where we've basically got the gingival margins right. And now, at this particular point here, the dentist has gone, that's fantastic. What do I do now? So the dentist has done a digital smile design. And so he's now decided, well, I'm going to do a bit of crown lengthening. So this is using the combination of orthodontics and all of your restorative knowledge. And so he's gone ahead and he's done a beautiful job on my hand. He's done the crown lengthening based on the stent of the digital smile design that he's performed. And then he's gone ahead and put some cosmetic veneers on. So here she is now. So here she is right now. This is where she basically first started. And this is going through the whole process. And we've now given her a really good, acceptable outcome, considering she had the ankylosed 1-1 to start off with. Over time, that 1-1 is going to stay there, and there might be some further eruption of the other teeth, but we'll deal with that at the time with possibly a new crown on the 1-1. Okay, so let's talk about some periodontal implications of orthodontic treatment. So when we treat these patients orthodontically, we talked about already the improved crown to root ratio. We can correct a lot of the gingival or osseous defects. We can get better self-maintenance of the periodontal health, and I believe we can get better space and root proximity. So for example, here, the tooth is mesially inclined, and we know as we upright that tooth and we extrude that tooth, what was a significant angular bony defect, which is a real problem periodontally, we could level that bony defect. So this is what we've been doing. We've known that by studies by Ingber back in the 1970s. Okay, we even have situations here where we can end up taking out a bad tooth and uprighting this other molar and improving the bone significantly by just that extrusion process that we demonstrated when we were doing that with the upper incisors. Same principle. And what I find very interesting, man, is we've learned at university that occlusal trauma plus inflammation gives you accelerated periodontal breakdown. And the academics will tell you occlusal trauma with no inflammation will give you no accelerated periodontal breakdown. And I would ask you guys as clinicians, how many patients have you seen that have no inflammation? The only patients that have no inflammation are those what we call notobiotic rats, which doesn't happen clinically. And orthodontics in itself, every time we do movement of teeth, there is occlusal trauma. So let me finish off with talking about a condition, and I'm sure you see it yourself, of older patients where they end up getting a maxillary diastema open. So they come in, they go, Geoff, I've got a gap open up in my two front teeth in the last few months. And what we coined the term in Philadelphia, posterior bite collapse. What happens is the patients get a loss of posterior vertical dimension. As a result, they get some mesial drifting of the posterior segments. They get a deepening of the bite anteriorly, and this is all associated and aggravated by occlusal trauma. And so to correct this condition, we've got to go back to the cause of the problem. We need to do some periotherapy, obviously. We need to restore the vertical dimension, upright the posterior segments. We need to obtain a good occlusal scheme and then restorative therapy to maintain that vertical dimension that we've lost and stabilise the occlusion. So what we used to do before we had bite turbos, etc., we used to use a Hawley bite plane because, as I said to you, orthodontic treatment is occlusal trauma in itself. The teeth would bang against each other. So we had to relieve the occlusion. So when the teeth were moving around, it was protected under an anterior bite plane. Now we would just put some composite bite turbos on, does the same thing, but the principles don't change. This is why when people say occlusal trauma will worsen the perio, if you're doing these periodontally compromised patients without protection of that occlusal trauma, absolutely it will worsen it. But if you know what you're doing and putting bite turbos on and protecting that patient from aggravated occlusal trauma, we can actually improve the periodontal condition. And I'm going to prove that to you right now. So this girl comes in. So this is going back nearly 30 years ago that I treated her. And look at the splayed anterior teeth. Now, a lot of you will see your older patients come in with this type of problem. But this is the 3, this is the 4. So this is not an extraction space. These are the teeth that splayed because of the poor occlusion. She's got posterior bite collapse. She's missing some posterior teeth. And so now what we've got to do is restore her vertical dimension and then move her teeth back. So this is how we proceeded. So we put in this is going back then, our bite plane to protect the teeth from moving and protect the occlusal trauma. We go ahead and line up the anterior teeth, close up the spaces, and this is how she finished 18 months into orthodontics. But she's still got the missing teeth. So and we put a Maryland bridge in here. If she does not get these missing teeth replaced, that posterior bite collapse will recur. So this is where back then it was going to be a bridge. Now today it would obviously be implants would be the ideal, provide this enough bone. But whatever it be, look at the difference. This is what we call life change. Okay? And I ask you the question, without the aid of orthodontics, or let's go one step further, without the aids of a proper interdisciplinary approach, because you need the prosthodontist. You guys could do your own orthodontics. This is not hard once you understand the principles, okay? Because orthodontics is really straightforward once you understand the principles, okay? So here we are. And this is going back as I said, close to 30 years ago. And I think it's a really nice case to demonstrate what posterior bite collapse can do. Once again, look at the improvement in the perio and the bone by getting the teeth in the right position. So if you look at it before and after, you would have to say the bone is better afterwards than before. And if you left this patient like they are, there's more occlusal trauma and the perio would get worse just by natural occlusal trauma. Okay? I get very passionate about this. So to finish up, we can teach you all of this stuff. This is just a little bit of one of our modules, module 8. You know, and so we do a 2.5-day course just on interdisciplinary treatment, basically. But I'm happy to have a discussion with anybody if they want, just to discuss what they can do in orthodontics, what they want to achieve, etc., etc. So I'm happy to do that. If you want to do this no obligation 45-minute call, go to orthotraining.com.au/session and you can book a time with me. Now, Race has done a great deal where basically if you're a race practitioner, just email Matt. Sorry for putting you into that, Matt. Email Matt and there's a code there and you can get $3,500 worth of Race dollars as credits as well. So you do the course, you sign up for our course and Race will give you $3,500 worth of Race dollars as credits, which I think is just fantastic. The reason being is both ourselves and Race, we work together a lot and we both understand the value of education. And that's what we want to try and provide to you guys. So on that note, I think I've been just on time and I'm happy to welcome any questions that you guys have. This was just a little snippet of interdisciplinary treatment, but just to give you an idea, there's so much there that can help you in orthodontics with your restorative work, and we'll go further in part 2 next week. Matt, any questions?
Oh, thank you very much, Jeff. Look, firstly, I thoroughly enjoy hearing the highlighted emphasis you put on the team and how important the collaboration between the team is, and I think that's reflective of a lot of your success, Jeff. You're definitely appreciative of what everyone has to offer, and I think it's definitely the best way forward. If you fail to plan, then you plan to fail. So I thoroughly enjoyed that. The comprehensive nature of your presentation, Jeff, has only led us to one question. So firstly, thank you. I'll take that question here, though. With regards to closing a black triangle,
Yep.
does decreasing the distance between the bone and the contact point increase the chance of soft tissue growth?
No, there won't be any soft tissue growth per se, okay? What happens is your papilla's got there's an X amount of papillae. And what we're doing is squeezing that papillae into a smaller space. So all the research has shown that if you get that contact point within 5 millimeters of the bone, you will never get a black triangle. And it's very rare in any research that's ever been done. I think it was from Tarnish. I think that was a guy, Tarnow. He did the research and he found 100% of the time, which is, in a dental point of view, unheard of that you ever get anything 100%. So even the worst type of problem, it's because your contact point is more than 5 millimeters away from the bone. If you can get your contact point, however you do it, within 5 millimeters of the bone. So that brings up the other part when you do your restorative work, you want to get your flat line angle. Because if you've got anything which is bulbous and you've got your contact point too incisal, you could end up with a black triangle. So you want to be getting, especially when you make temporary crowns, getting flatter line angles for that reason.
Okay. Yeah, I do believe it is the Tarnow rule. It is a dentist from New York.
Yeah, I think it was Dennis Tarnow.
Yes, I think you're right.
Yep.
Look, I again, thank you very much. There are no more questions, Jeff. I think your comprehensive coverage is pretty self-explanatory there. I would like to reiterate the part 2 of this series next week. Is that right, Jeff?
That's exactly right. Yep.
Okay. Well, I look forward to getting you all back on for next week's Race Dental Academy webinar series, but I'm just double checking there's no extra questions. If you do have any questions, feel free to contact us at Race. If there's anything you'd like to watch again, we do have a copy of all of our webinars that go up on our website at racedental.com.au. Feel free to go into the education component and check out these videos if there's anything you'd like to see from Geoff as well. If there's any topics that you'd like us to cover as well, feel free to send them to Geoff or myself. We'd love to address any relevant topics that you guys see fit. So again, I would like to thank you all for joining us. Dr. Geoff Hall, thank you so much for your time. We do appreciate you sharing your knowledge. Is there anything else you'd like to add?
No, I just want to say thank you, Matt, and I really very few people spend so much time on education what you guys do, and I think it's just absolutely fantastic for the dental profession, and you really deserve the recognition that you get in the dental space. And I thank you for spending so much time helping dentists and ourselves, with the education process. So thanks very much.
You're very welcome. So that goes a long way. We do appreciate our clientele, and helping them grow is helping us grow. So if there's any more information you need, feel free to jump on the website or contact me directly at matt@racedental.com.au. And I'd like to thank you all for participation, and we'll see you all next week.
Thanks, Matt. See everybody. Bye-bye.